Ischemic heart disease is a discussion for the day. The points I'm going to talk about is we're going to go over coronary circulation normal first, and then we're going to go what actually limits coronary circulation, some of the compensatory mechanisms that you will see in clinical as well as in your patients, and what can happen if you develop coronary occlusion syndromes, developing of ischemia initially, then followed by infarct, the different forms of ischemic patterns we're going to discuss, and then we're going to talk a little bit about, as we go along, about the anesthetic effects on coronary circulation. In the coexisting course, we will go over this again, but in more detail towards the anesthesia-related problems. Right now, it's just the pathophysiology that we're really concentrating on. The normal coronary circulation, first of all, originates in the aorta, okay? And you have two main branches that originate from the aorta, which is the right coronary artery and the left main artery, okay? These are very important as their actual distribution and their actual origin point. The origin point is just right after the aortic valve, okay? So it's considered one of the first arteries that branches off the aorta. That might be not necessarily my test question, but somebody might ask that to you one day. What is the first artery that branches off the aorta? And the answer is the coronaries. That's the first ones that come off, okay? Now, you can actually visually see these under TEE, transesophageal echocardiography, so it's important to know its anatomical position. The left main coronary artery is coming off the left coronary cusp. Okay? You can actually measure the flow patterns of flow velocity using echo. And through the left main, that actually distributes to pretty much all of the left ventricle. The left main is also considered the widowmaker, okay? Because if you develop an occlusion in the left main, you lose all function of the left ventricle, which of course is going to lose all systemic arterial pressure, and the person will not survive. The main reason also the left main is also a significant widowmaker is that patients will develop a left bundle branch block that's a new onset, or will develop a significant malignant arrhythmia, such as VTAC, VFib from this. So it's one of the things that you have to be concerned about. The left main divides into two major arteries, which are the left anterior descending and the left circumflex. The left anterior descending provides the diagonal branches, which are called D1, D2, depending on the location, and left circumflex has what's called the obtuse marginal, and some books will just call it the marginal arteries that branch off it. The right coronary artery comes off the RCC area, which is the right coronary cusp area, and immediately divides into the marginal artery and another artery that sort of runs along the atrial sulcus. What's interesting about this is that the right coronary artery provides most of the blood supply to the SA node, and as well as to the AV node. So when you see RCA disease, these people present with significant bradyarrhythmias. Okay, so bradyarrhythmias you should think in the back of your mind, right coronary artery disease. If you see VTAC, VFib, think left main or LID disease. When you look at it from the top view, you can actually see how the actual right coronary artery, this is an anterior view, sorry, showing you the aorta, how it actually goes posterior to the pulmonary artery. Anterior to the heart is the actual pulmonary artery and the pulmonic valve. Immediately posterior to that is the aortic valve with the first branches of the RCA and the left main. Okay? The left main is kind of an interesting structure in the sense that it's in between the pulmonary artery structure and the actual venous return. And in some anomalies, it actually rotates around the pulmonary artery, and when the person develops pulmonary hypertension, may actually occlude the left main from the actual direct compression. So there is anomalies that are out there that can cause significant problems in some individuals. Some people actually will do fine. Imagine having this problem. Imagine having an anomaly over the pulmonary artery. And you're basically normal activity, no symptoms at all. No symptoms. Excuse me. You get no symptoms at all. But then now you're walking around and you decide to start running. And in the middle of your run, you develop an elevated pulmonary hypertension, and then all of a sudden you get an occlusion of your left main, and you get it going to VTAC or VFib, and that person will basically pass away from just that significant arrhythmia, even though they appear totally normal. And when you take them to the actual autopsy, they will have normal looking arteries, except this anomaly will actually overlay over the pulmonary structures. If you see, this is a normal setup, okay? You see that this is a shot from below, showing the pulmonary arteries over here, and this is your aorta. This is what we call the RCC, or also the way this book is written is RSV, which is the right valve, okay? This is the LCC, which is where your left coronary cusp is where the left main comes off of. This is a normal setup. What I was talking to you about before is the left main wraps around the pulmonary artery and comes back around. That's considered one of the anomalies that occurs in about 5% of the population. Again, this is the kind of structure that I expect you to know for your test. From anterior, posterior locations, your most anterior valve is your pulmonic valve. Immediately behind that is your actual aortic valve, okay? Which is the next one behind that is your tricuspid valve, and the most posterior is your mitral valve. Okay. Again, this is a nice drawing showing you how the aorta has the first branching arteries coming off, which is the RCA and the left main. Now, what's really interesting about coronary perfusion and compared to any other organ system in your body, and you guys all have looked at kidneys before, or at least seen them in pictures, or you've looked at, let's see, what's a good example of that as well, intestinal tracts or liver. What do you always see? You always see an artery coming into the organ, and then it's like penetrates into the organ. The coronaries are very different. It's one of the only organ systems where you actually have the major arteries are actually running on the surface of the organ, which is kind of unique, okay? Which is, what's actually so unique about it is that we can actually repair those arteries. The ones that are inside your liver, you would have to cut the liver all the way through to actually be able to get to the artery and fix it. So that would be actually very difficult to fix, okay? But in the sense that we have the ability to fix our coronaries because the coronaries actually overlay over the top, the surface of the actual heart itself. Now, as the arteries begin to travel along the route, we can actually diagnose coronary artery disease by shooting dye into the actual coronaries themselves. We actually will put a catheter into the left main or the RCA. You know, we do both, different times, and then we shoot dye into them, and then we actually see the anatomical surface of the heart, what the coronaries are like. And it's not until you get down to the medium-sized or small arteries that the actual coronaries dive into and perforate into the actual myocardium. So we can actually repair the larger epicardial arteries rather easily, but where the limitation is at is that you can't really repair the medium size or the arterials inside the network. And that's why some people actually will present with this ongoing ischemic disease that you look at their coronaries and they look okay. But what they actually have is that they have small vessel disease. What's the disease process that will actually give you small vessel disease? Diabetes. Very good. Diabetes is a classic example of that. Some of the inflammatory diseases that we'll talk about in cardiomyopathies will also cause these small vessel attacks. Okay? Things like scleroderma, those will attack more of the small vessel and arterioles, and you will see obliteration of them, which then develops a cardiomyopathy in the end run. So this is what you actually will see when you look at the. This is a nice drawing that I actually found recently. This shows you the also LAD, which is the left anterior descending artery, and then it perforates through the epicardial surface, and then you can see how it goes from the large vessel, which we call the epicardial coronaries, and then becomes a medium size and eventually into the arterial capillary network. Okay? What's important to you to notice is that there is an extensive capillary network inside your myometrium. Okay, this is the actual muscular layer. So the blood that's being delivered there is going to be very high in oxygen content. The actual oxygen extraction rate for this area is around 80%. So you're really soaking up all the oxygen pretty much that's in the blood. And it's kind of important that it's right off the aorta where no other organ system is actually taking up any oxygen to use. What's nice about this picture is it shows you the basin veins. The basin veins are basically a connection between the endocardial surface all the way to the LAD, which is a vein, which is the actual venous return system. Okay, and eventually this venous return becomes part of what? Choroid sinus. Okay, very good. We actually had this, the reason I kind of brought this up was because the other day I was watching them put in what's called epicardial pacemaker leads in people. And the way they do them is they actually will feed them through the coronary sinus and feed them back into the actual vein, and that's where the actual lead will be at. Okay? This is when they're actually doing biventricular pacing. So they're pacing both ventricles at the same time instead of the normal side, which is the RV. Most pacemakers that are available are fired from the RV side. The downside to that is it delays the signal to the left side. And what will actually happen is the right ventricle will actually initiate contraction before the left side, and the septal wall will actually shift towards the left, which impedes left ventricular filling. And as a consequence, people that are already marginal, let's say with cardiac outputs of 10 or 15%, become even more symptomatic. Now, when you put a biventricular pacer wire in, now the actual wire fires a little bit earlier for the left ventricle, and now the ventricle stays full and is able to eject more efficiently. So it's actually a new form of therapy that's actually been very effective. Okay, so these are the actual connections that you have in the system. Now, one thing I want you to sort of pay attention to, which we're going to talk about a lot in perfusion, is that this area here, great, it doesn't work. Why not? It couldn't be. It doesn't work, okay. Sorry. Here it goes. This area here is the area that's going to get compressed when the ventricle begins to contract. Okay? That area gets compressed so hard that actually blood flow will stop. Okay? So during systole, which is specifically the left ventricle, you will see no real perfusions taking place in the myometrium. The right side of the story is a little bit different because what's your pressure gradient that you have coming from here? Where's it coming from? It's coming from the aorta, right? So that's a pretty good pressure head, okay? In this sense, since what we use for coronary perfusion pressures, we use ADP. So a normal ADP is, say, 60, okay? And what's your maximum PA pressure? It's around 20, okay, or 25. So that still gives you a gradient of around 40 to 35, so that means you still got blood flow going through there. Versus the left ventricle, during systole, the pressure goes all the way up to 100, 120, so now you've got a zero gradient. You've got no pressure that can occur. I'll show you that next. Okay? So when you're looking at perfusion, you have to look in the back, you have to think in the back of your mind that you're actually looking at it from the sense of each ventricle perfuses slightly differently. The reason that we use the main equation, which is coronary perfusion equation, which is ADP minus left ventricular and diastolic pressure, because that's the most important one. You lose the left ventricle, game's over. Okay? You can actually lose the right ventricle and you can still survive. But you lose the left ventricle and develop ischemia that side, the ventricle can no longer eject to the heart, to the brain, and the game's over very quickly. Okay? So that's why we use that as our primary equation. But the other way you could look at this is that you can actually say, well, if I want to look at coronary perfusion pressure to the right ventricle, what I would use as my perfusion pressure difference would be ADP, which is what's originating from the aorta, minus, in this case, your right ventricular end diastolic pressure. And your right ventricular end diastolic pressure is actually a lot lower than it is as in your left ventricle. Now let's run this through. In this case, we're looking at the left ventricle. This is a pressure volume loop. So we'll look at it from the point of view where the mitral valve closes. So at this point, this is the mitral valve that's closed here. Mitral valve is closed here. And where you see for your coronary perfusion, at that flow, your blood flow is still ongoing. But immediately after that, as you get isovolumetric contraction taking place, what happens to perfusion? It goes to zero. The reason it's going to zero is because you have this pressure that's going from, let's say, 10 to 15, and it's going all the way to 100. And you have no more perfusion pressure that allows, there's no gradient. It's zeroed out. Okay, so flow goes to zero. Then as you go further into the cycle, when the ventricle begins to open up the aortic valve, you'll see that now the aortic valve allows ejection and perfusion resumes. It comes back up. It's not great, but it does come back up. So it's not through the whole systolic cycle. It's the actual portion that has the zero flow is during the isovolumetric phase. Okay? And that's really important because why? Because if I make you have severe hypertension, let's say I drive you up to a 220 blood pressure range, then I have to spend a greater amount of time in isovolumetric time. And that means that perfusion is going to go lower for extended periods of time. And that puts the heart at risk for having ischemia. Okay? Now, as you go back through the cycle, the best perfusion occurs when the actual mitral valve is at this point is open, and you can actually see the isovolumetric relaxation phase. So the pressure inside the ventricle drops off dramatically. So the maximum amount of perfusion is actually occurring at the point where the mitral valve is just opening. Okay, that's when your perfusion is greatest. So diastole is a point of greatest perfusion that it takes place in the ventricle, for the left ventricle. If you look at the right coronary artery, so I'm going to do a little switch over here, so pay attention to the board, okay? I'm going to switch it over now to same pressure volume loop, but I'm going to change it to make it a right ventricular pressure volume loop with limited pressures. Instead of going to 100, now I'm only going to a maximum pressure of 20, because that's the PA pressure that you're pushing it against. When the tricuspid valve is closed, perfusion is at its lowest point. But it never goes to zero. Perfusion is still maintained, and you can see even during isovolumetric contraction, that's your lowest point, okay? You're still not going to zero, okay? You're actually continuing to increase to the point where now the maximum perfusion for the right ventricle is actually occurring during systole, which is kind of strange. Okay, so if they ever ask you that in the test question, which is the side that perfuses best in the right ventricle, the answer is systole. But most people will ask you, what is coronary perfusion? When they ask you that question in the test or the boards, they'll ask you, where is coronary perfusion at its optimum? And the answer should be at diastole, because most people think of left ventricle. But if they go into specifics and say to you, when is perfusion optimum for the right ventricle, you have to actually say during systole. Okay? I'm not going to try to confuse you like that in tests. I just want you to understand that. But still, you still get a lot of a good perfusion during diastole for the right coronary artery because you have a long duration time underneath this curve. So you still have pretty good perfusion during that time. Okay? Go on to the next one. Now, ischemic heart disease is a simple definition. It's basically when metabolic oxygen supply is outstripped by its demand. Okay, so that means demand now is beyond what you can actually supply. Most of the time when people hear ischemic heart disease, they immediately think of inadequate perfusion, which is okay, which is 99% of the disease processes that we develop with ischemic heart disease is due to some inadequate perfusion. So that's what we call coronary ischemic heart disease, okay? Or what's called atherosclerotic coronary artery disease, okay? And that has to do with that equation, which is coronary perfusion equals ADP minus left ventricular diastolic pressure. But there's, yes? Aortic diastolic pressure. Okay. The high demand problems, on the other hand, are hypermetabolic syndromes. Patients that have thyroid storm, that are in malignant hyperthermia, that are in neuroleptic malignant syndrome, people that are under severe high stress heat, so heat cramps to increases in fever. So anything that causes that kind of high demand will also put you into ischemic heart disease. If you also have inadequate oxygen carrying capacity from anemia, you can also develop ischemic heart disease. Okay, so if somebody with anemia over long periods of time can really develop significant ischemic disease damage, even though they have normal coronaries. Okay? And people will become really, really symptomatic, and even young people will do that. You'll get them short of breath for no known reason. You'll see that they'll come back home and say, hey, I can't breathe or something like that, and that's where you have to pick up anemias from. Lack of oxygen leads to ischemia, diastolic dysfunction, which is a very severe problem. That's the first sign that you're developing ischemia. Okay? Diastolic dysfunction occurs because you're no longer having enough oxygen to provide the ATP. And ATP, when we talked about this last semester, what's ATP for? It's to break the bonds between the myosin heads to the actual thin filaments, okay, which is the actin. So because that, the ventricle becomes more rigid, and with that rigidity, the compliance drops down, and it takes more volume to actually fill that ventricle to a acceptable position to actually give you enough of a cardiac output. If you wait too much longer, then the next part you'll have is electrical dysfunction, which is you'll get PVCs, you'll get into atrial arrhythmias, you'll get into bundle branch blocks, you get into all these electrical problems, and you should immediately think in the back of your mind, the reason that is because it's the electrical component of the heart is not in the myometrium, it's in the deeper structure, which is the subendocardium. And the subendocardium is really the furthest distance from the epicardial vessels. So it's more likely to develop kind of a weird electrical pattern early before you get myometrial ischemic patterns. And when you get myometrial ischemic patterns, then you start impairing contractility. And that becomes a real problem. Okay? And if you wait too much longer than that, then it develops infarct. Infarct can then go into aneurysmal formations, scar formations, and into also rupture of the heart. So not very common, thank goodness, but it can happen. So what's your most common one, which is your coronary artery disease? It's mostly due to atherosclerosis. It results basically in about a third of all Western society deaths, and actually it's continuing to increase despite all the advancements we have. And one of the things that we used to, and I still don't go into all the detail, I think that's part of the DNAP course, is that we don't go into all the endothelial function. 20 years ago, the basic structure was told with atherosclerosis is just a disease pattern where you have abnormal blockage of the artery. And actually now it's a much more complicated than that. We understand that the endothelial structures are really important to release certain kinds of chemical agents to prevent thrombosis from forming. And it also allows for vasodilation to take place. So there's actually, and there's also neural networks that connect in this area as well, which all control the coronary blood flow. But it's still a very considerable problem in our society, in all Western societies, and it causes a major cause of perioperative morbidity and mortality rate. By the age of 65, 37% of men and 18% of women have coronary artery disease. Severe stress can also accelerate atherosclerotic coronary artery disease. And they found that's in Korea during the Korean conflict, during the Korean War. They actually did autopsies on 18-year-old boys. They found that a lot of them had, about 18 to 20% of them already had advanced coronary artery disease at 18 years of age. And when they actually saw that a few years later, when they re-examined it, they found that when they look at that population again, that the incidence was maybe 1 or 2%. So they imagined that the stress of combat that was actually inducing the rapid acceleration of coronary artery disease. Now, there is some modifiable risk factors, and there's non-modifiable risk factors. And the non-modifiable risk factors are things that you can't really change as advanced age. So as you begin to move towards the age of 80, like we have here, everybody has coronary artery disease. But it risk stratifies. Where it risk stratifies is around the age of 50 to 55 to 60. If you look at most patients that come in with significant coronary artery disease, they come in at the age of 60. And most of them are dead by the time they're age of 70. Okay, so what's happening is the 80-year-olds that we take care of are the ones that actually survived. They got past that section. So a lot of times you'll see 80-year-olds that you put them to sleep and you go like, should I be worried? And if they don't have any symptoms, the answer is not really. They're the ones that are survivors. The ones you have to worry more about are the actual 60-year-olds and early 70-year-olds. They're still in the high-risk group that's peaking, and then those people may be the ones that develop ischemia during anesthesia. Male gender, a lot of times in the past, they was associated just with testosterone. There was a reason for it, or estrogen protected women. They actually found that's not necessarily the case. It has to do with the actual hemoglobin levels in the bloodstream. The recent study that was developed in Sweden or in Norway, I can't remember which one right now, but one of the Scandinavian countries. And what they did was they took a sample of population for almost 30 years, and they looked at the men that gave blood. The men they actually donated and they gave transfusions themselves every month. They had the same incidence as women, and they also had hemoglobins more similar to women. They were menstruating, and that's what they think is the cardioprotective effects. We do know now that hemoglobin, when it breaks down into the iron component, the ferritin, is the one that actually damages the endothelial wall. So if your hemoglobin is higher, what's your chances of damaging the endothelial wall? They would tend to go up. So if you're a high-risk group, you may want to consider giving transfusions every month because it actually may reduce your risk of developing coronary artery disease. The other and also, of course, hereditary. If you have a family member that's over the age of 50 that's developed a coronary artery disease or had an MI, and if you're a male, if you're over the age of 60 as a female and they developed coronary artery disease, that's considered a high-risk group, and most likely, if you're at the heredity with them, you're more likely to develop coronary artery disease. The modifiable risk factors has to do with diet. It's to a certain degree dyslipidemia, depending on your how you actually eat. Some familial groups too, they process fats differently. For some reason, Italians seem to process fats a little bit differently and produce a high elevated LDL levels in comparison to HDL. We're not exactly sure why that is. It's not because of the virgin olive oil diet that is actually protective, but it's when you switch over to a that kind of diet plan with virgin olive oil that you get into trouble. So you have to be watching those kind of patients of Mediterranean origin a little bit more carefully because they tend to develop dyslipidemia at the higher rates. Tobacco smoking, of course, is a bad idea. Hypertension, also a bad idea to continue having if you're not treating it. Diabetes or metabolic syndrome, also called syndrome X, is a patient develops central obesity pattern, high blood pressure, high triglycerides, low HDL levels, and insulin resistance. All those people have much higher risk factors. Most of the time, this is alleviated mostly by weight loss and changes in dietary plan. And there's also, of course, people that have lack physical exercise that also increases your risk factors. The reason that the physical exercise has to do with it is most likely that you release certain hormones in your bloodstream that actually drive LDLs down and drive HDLs up during exercise, as well as increasing your actual arterial compliance from exercise from increasing blood flow velocity. The biomarkers that we actually are seeing that are also indicators of increased risk is elevated homocysteine levels. Homocysteine is a protein component, and we find that people that have homocysteine levels that are elevated are more prone to develop damage to the endothelial wall. We think that homocysteine can be protective in the sense that it actually helps the endothelial wall maintain its integrity, and when you have elevated levels, it may indicate that you have ongoing damage for an inability to uptake the homocysteine into the endothelial cells themselves. You can also have lipoprotein A that's elevated. Okay, lipoprotein A is a kind of LDL that it basically is an indicator of it encourages inflammation, and as well as it encourages coagulation, and that's why lipoprotein A is not a good sign to have elevated. And the newer test is called CARP, or C-reactive protein. The book calls it C-reactive protein. If you go to the hospital here, they call it CARP, which is C-activated reactive protein. What it basically indicates, it's a complement cascade byproduct. So it indicates that complement activation has taken place, and it's a marker of inflammation. So you see that CARPs are elevated in people with rheumatoid arthritis, anybody that has any kind of inflammatory process. While inflammation is also a sign of internal inflammation in the endothelial wall, and that will make you more likely to develop thrombosis and coagulate out and cause, of course, your MI in this case. So when you look at your actual determinants of supply and demand, you look at the oxygen content, and it's, of course, very important. So that has to do with anemia. That has to do with your blood flow itself. The coronary blood flow, of course, has to be related to coronary perfusion pressure, coronary vascular resistance. It could also be affected by external compression, like I just talked to you about that earlier. Intrinsic regulation, such as the actual endothelial wall, releasing certain kinds of enzymes and markers to keep the blood vessel dilated. There's also local metabolites, such as, what's the name of it right now? Adenosine. Adenosine will cause vasodilation to take place in the coronaries, as well as nitric oxide. And also endothelial factors and neuroinnervation. The things that increase your demand are increases in wall stress. So anything that increases your intraventricular pressures and tension, as well as the actual viscosity in the blood, will also increase stress and demand. Heart rate increases are a bad thing, and increases in contractility also put more demand and can actually push the person over into developing ischemia. Coronary ischemia can be looked at simply from the actual coronary perfusion equation, which is your aortic diastolic pressure minus your left ventricular end diastolic pressure. Things that will cause decreases in ADP will be, of course, things that decrease your SVR. If you have decreases in preload, such as in hypovolemic shock, will also lead to decreases in ADP. So somebody who's hemorrhaging or somebody who's become severely dehydrated. Patients that develop severe decreases in contractility can also lead to a decrease in ADP. And also, of course, malignant arrhythmias or even simple arrhythmias such as atrial fib or atrial flutter can impact preload return to the heart and then decrease your ADP. On the other hand, what actually will increase LV-EDP will things that cause excessive preload, such as volume overload conditions. If you give somebody 6 liters of fluid on them, you may actually push them into ischemia and develop congestive heart failure. We'll talk about later on. Tachycardia may also increase LV-EDP because it doesn't allow the heart to fully empty. When you're normally talking about tachycardia that we talk about is anywhere between 100 and 120 is actually good because actually it's able to empty the heart a little more efficiently. But once you get above 120, that's when the ventricle now can't empty. It doesn't have enough time, so it now begins to fill, and that's not good. So too fast a heart rate is actually not good for you. Severe aortic stenosis can also be a problem, of course, because of the increased afterload effects from just the valve not opening. And you also get a decreased ventricular compliance simply because the ventricle hypertrophies and becomes thickened, so it increases the risk of developing ischemia from that as well. And acute aortic insufficiency will dilate and cause an increase in LV-EDV with LV-EDP as well. And coronary ischemia can also be in normal coronaries, which we'll talk about a little later, which is called Prinzmetal's angina, which is from coronary vasospasms or from anatomic obstruction. From, let's say, a catheter breaks off, wire breaks off. You may be surprised at what you see. I've even actually seen a parasite get into a coronary artery, and that was pretty almost lethal to that individual. It was a little bit different, to say the least. But he actually got infected from the heartworms from his dog, of all things, and actually got into his heart, just like it would be in a dog. It was kind of interesting. We always been told that you couldn't get heartworms from animals, but I think it's one of those rare events. I think the guy was scratched up quite a bit by the animal all the time. So It was interesting, though, your presentation. What you have is a normal compensatory mechanism. If you have a healthy individual, when you start to exercise, one of the things that immediately is activated is your sympathetic nervous system. And when your sympathetic nervous system becomes activated, you tend to normally increase your systolic blood pressure as well as your ADP. Your actual ADP rises at a faster rate than your systolic pressure many times. Okay? If you look at the actual picture up here in the B, you will see that the diastolic pressure increases tremendously in a healthy individual during exercise, and that actually is equivalent to what the balloon pump does. It drives the diastolic pressure up to actually increase your forward coronary blood flow. If you look at a person who has coronary obstruction, though, even though the diastolic pressure may be actually rising, it cannot go up because the obstruction is actually inhibiting that diastolic pressure from being generated past the obstruction point. So in that sense, you don't really get an increase in perfusion velocity with exercise when you have somebody with significant coronary artery disease. And that's why they become symptomatic on exercise. Under normal conditions, the curves look the same between a healthy person and somebody with acute significant coronary artery disease. But you see the major difference is when you exercise. When you exercise, that's when you see the perfusion pressure does not keep up with the need, the increased demand, and the person becomes symptomatic. Now, the endothelial factors that are important for control of vasomotor tone, what this picture is basically showing you is the cross-sectional cut of the coronary artery. So you're actually looking at the intima here. So let me redraw this, it makes more sense. You have a coronary artery, looks like this. Okay? They've actually taken this section here and they cut away from it. And now they've got the actual muscle here, the endothelial level is in here, and the actual the adventitia layer of the artery on the outside, which is what this is. This is the adventitia. That would be this. The media is here, and the intima is here. Okay, so they cut that away. And what we're finding out is that this, the actual vasomotor tone, which is the actual blood vessel itself, is controlled by many chemical signals. And that interaction that's taking place is like this concert that's going on constantly with chemicals basically either inhibiting or activating the vasomotor tone. The ones that do the most vasodilation are nitric oxide and prostaglandin I2, okay, which is a very potent coronary vasodilators. That's why nitroglycerin works. Nitroglycerin is a nitric oxide releaser, okay? So it's a very effective as a vasomotor inhibitor. On the other hand, you have other agents like norepinephrine or endotoxin that can release and cause a severe coronary vasospasm taking place. You can also have circulating hormones such as, of course, insulin mostly epinephrine. Norepinephrine can actually bypass your, depending on what the dosing level is, can actually inhibit or activate vasomotor tone. So I just want to show you this picture. I'm not going to ask you anything specific about this. I just want you to understand that when you're giving somebody like nitroglycerin, that you should expect that it's not really working at the endothelial level. It's actually penetrating through and that causes an activation and release of nitric oxide next to the vasomotor area, which then causes the muscle to relax and causing coronary vasodilation. Now, when patients develop symptoms, they develop what we call stable angina. Stable angina, what we were taught was this initial picture, which is to the typical chest distribution, which is the anterior chest, going down the hand. Of course, it's down the left hand. It's down usually in the C6, C7 distribution. The reason it's running in that direction is that's where your actual connection is to the heart, so it actually is in that same distribution. You get you also get atypical chest pain, so you can see the different patterns. People will refer to epigastric pain or shoulder pain or neck pain. So you got sort of, the reason I'm showing you this is that when people complain of some kind of discomfort after surgery and it's not related to the actual surgical incision, you really got to think in the back of your mind, is it coronary artery disease and I'm not picking up? So how do you actually figure out if it is? And the answer is a person undergoing a tremendous amount of stress right now? Is their heart rate elevated? Are they coming off beta blockers and now their heart is taking off on you? Is the blood pressure super high? Is the blood pressure really low? Which of course that will cause ischemia as well. So you got to sort of look at the patient over a little bit more carefully. If you think it's ischemia, then give them a little nitroglycerin, see what happens. Of course, I would then immediately support them with additional oxygen. And if it's pain-related as well, give them morphine, which we'll show you that in a little bit later in the different treatment plans. But these are the difficult symptoms that the person will get. Now, what stable angina basically means is that it's stable. That means that individual is having significant coronary disease, which is a range of 50 to 70% occlusion. And once you get over 70%, you may then go into the unstable angina symptoms. But right around 70%, this point of maximal compensation, and really that person after that really can't make any more headway. And when you put them under exercise stress, you will see that the angina will come on as a consequence. So usually stable angina comes on not at rest, but rather when exercise. What the individual will develop is they'll get ST segment depression, and depending on where the coronary artery is going, where the actual disease is at, they'll get anterior, lateral, or inferior EKG changes. Okay? The good thing about the stable angina is once you put them at rest, the ST segments will resolve, okay, which is the ST segment depressions, will resolve back to normal, and the person will basically not have any more chest pain. But what it's trying to tell you is that, hey, this person has significant disease, and they need to have something done fairly soon. Unstable angina is one of those things that you should never really let the patient go home with. Okay? These are the people that can go into VTAC at any moment, or go into failure, or develop an infarct soon. What you see is these people develop an abrupt increase in severity, frequency, or duration of anginal attacks. Okay? I had one patient come in one time at a preoperative clinic, and he told me, well, you know, I've been feeling too well. I said, well, what did you used to do? And I said, well, I used to go to my mailbox. And then his wife chimed in and said, we haven't gone to your mailbox in the last 3 weeks. So when you ask him a little more specific, why haven't you gone to the mailbox? Well, when I go to the mailbox, I get chest pain. And that's not the way it was 3 weeks ago. I said, no, but I want my knee done. No. He went and had his actual cardiac cath done and showed that he had 90% left main. And that'll kill you pretty quick. Okay? So he actually went directly from there to open heart surgery. And then he had his knee about 6 weeks later. Okay? You always take care of the heart first, because even though the heart is the main organ to pump antibiotics to the bone, you can't really live without it. So that's what usually the orthopedic surgeons call the heart. It's the pumper of the actual antibiotics to the bone. So angina at rest will be a problem. That's considered unstable angina. Okay? Or the pain becomes severe in the last 2 months with increase in frequent episodes. It basically indicates over 80% stenosis, which is indicating severe coronary disease, and usually will precede MI. Okay, these people are just disasters waiting to happen. What I would tend to do is I'd put them in the ICU immediately and get them worked up by the cardiologist. If not, at least I pick up the phone call and make a call to the cardiologist, say, hey, look, I got this patient with these kind of symptoms. He's gotten worse in the last few weeks, and I'm concerned about, could you put him in the hospital? And it says, no, but send him over to my office right away. I said, okay, that's fine, but at least now you've got the phone call saying that you called and said that you're trying to move the patient back into the hospital, which is what you're trying to do. Most of the time, these people, if it's really significant, they'll put them in the hospital right away, and they will get tested within 24 hours, in the United States. In other countries, they'll put you on a 6-month waiting list, and if you die in that time period, well, you've stratified yourself out. Management, nitrates and beta blockers are the principal therapies because nitrates are vasodilators of coronary, and the beta blockers slow down workload, so it limits the actual management. The problem with beta blockers, of course, if the person develops a heart failure, it will push them into heart failure even faster, which we'll talk about in the next hour. And no resolution then to go for a cath lab. Prinzmetal's angina is a variant angina in the sense that it's a total normal coronary normally, and it's usually due to an inability for the endothelial cells to regulate vasomotor tone. So these people will develop unusual high levels of acute coronary vasospasms. And this is what you'll see. You see massive ST segment elevations in these individuals. This looks almost like tombstoning. and usually it will be present at rest. So most of these people will immediately be taken to cath lab because they're having so much chest pain. They're usually very young, usually in their 30s or 40s, and it's usually not a good sign in the sense that you think that person's having an active MI. The good thing is that it is a vasospasm, not really a disease, and it is treatable with some degree of calcium channel blockers and nitrates. If you wait too long, the next thing that will happen is, like in this nice pathological exam, you'll pass away. But in the interim, you will actually develop a significant disease process where you'll begin to infarct different portions of the ventricle. What this picture is showing you is that it's showing you a healed area where the person had an infarct. And then you can see the white banding. That's scar tissue. So what do you think the contractility is going to be like in that area? 0. Okay? So one of the things that happens with coronary artery disease is that you will lose myocardial muscle mass. If you see this, you can see the acute versus the subacute. The subacute gets an inflammatory process. It looks pretty nasty looking. And the person will continue to have microinfarcts or continue to damage the myocardium. And eventually, if you don't fix this problem, the person will develop congestive heart failure. What you see with the myocardial infarction is you don't get ST segment depression, you get ST segment elevation. And you'll get eventually what's called tombstones. The reason you got tombstones is because that's where the person's going to end up, in that box, if you don't do something pretty quick. Okay? Acute thrombosis is the main initiating event, so the treatment is to reverse that thrombosis as fast as possible. One thing that can actually be life-saving for people is giving them aspirin as soon as they're developing symptoms of a myocardial infarction, because you're basically preventing platelet aggregation from taking place. The next step, of course, is your thrombolytic therapy, which is also going to break down the clots and hopefully reperfuse the tissue, and then possibly putting stents in and going to the next step. The acute treatment, if somebody is complaining of chest pain to you, and you should immediately think of MONA, which is morphine, oxygen, nitrates, and aspirin. Morphine acts as a preload reducer. It decreases sympathetic tone, decreases heart rate. Oxygen, of course, if the greater PaO2, the greater the actual saturation, if the person's desaturating, is going to help. Nitrates are vasodilators of coronary structures, and aspirin, of course, inhibits thrombosis. Beta blockers, I think, is a little bit tricky. You should consider giving them, but as long as you're not in failure, that's where I think the limitation is. Don't give it to patients that are already in fluid pulmonary edema. Good way to kill somebody pretty quick is giving them beta blockers. I've seen people do that in the ER, and I'm sort of not impressed. Calcium channel blockers may be also a consideration, but really it's a long-term therapy. And if you're really getting to a situation where things are not really working, take that person to the cath lab where they can give them thrombolytics. Now, the problem is that we usually see these people or they're post-operative, and that's why we leave it to MONA, because really the last 3 regimens are very limited in the sense that when a person has, especially the last one, has a surgical incision and you give a thrombolytic, you can actually cause them to hemorrhage to death. Kind of a real problem. I saw that done one time where the patient had a total hip replacement. They had already bled around 500 cc's, and the next hour they bled 3,000 cc's out their wound. So you can lose a little bit of blood. So we had to give the guy 4 units of blood, or 8 units of blood to keep up. So you can lose a lot of volume, so be careful. Now, the last part of this discussion is on balloon pumps. I don't know how many of you have used them before, but one of the things that can be life-saving when you have to increase your coronary blood flow. What balloon pumps basically do is that they're diastolic compression devices. What they do is they inflate during diastole within the aorta, and when they do that, they increase the diastolic perfusion pressure and improve coronary perfusion pressure as a result. It is extremely dangerous to inflate the the balloon during systole. Systole events would be catastrophic in the sense that it would increase afterload so much that the left ventricle will then have a tremendous back pressure on it and may actually induce a worsening MI and may actually have more deleterious effects than that, actually a cardiac rupture. So balloon should always be inflated during diastole. So this is what we just look at this over on your own. It goes through a little bit of different things that you should look for when you're giving the balloon. And the last one is a slide that I think is in case you get into a catastrophic event and the person arrests on you. This is a great study that was done a few years ago where they actually show what happens when you actually are giving somebody cardiac compressions and when you ventilate. Look what happens when the person ventilates. What happens to the diastolic pressure? It goes to 0. Okay? So I'm not a real fan of ventilating people when I'm doing cardiac compressions. I tell people, give them 100% oxygen, give them 2 breaths, then that's it. Don't give any more until we start this guy back up. Okay? Because the oxygen in the lungs are going to sit there until you get perfusion going again. So there's no point in it. Okay? And what you're trying to do is you're trying to drive the diastolic pressure up to a point that the heart turns over. And every time the person was being ventilated, you can see that the perfusion pressure fell down, and you're back to starting all over again. Versus if you continue doing this, the vessel pressures would be way up in this point. It would actually, you can actually follow the line. You can actually see this line, this slope of attack. This will tell you how long it will take to get to a point where you want to basically flip the heart over. So if they continued without giving that person compression for 30 seconds, they would have gotten that person back. And that's the point of that slide.